Good evening, everybody. I'm sorry for the delay. I got caught up as Dr. Roy informed everyone. Now, today's topic we have taken as prostate. Where is the presentation? Prostate and its myths and facts. Prostate itself is a huge chapter. So we are going to concentrate on the benign prostate part, because taking benign prostate as well as prostate cancer together would be a huge task and it wouldn't fit within the time limits that we have. Hence, we will talk something about the prostate cancer as well, but mostly we'll be talking about the benign prostatic hyperplasia.
I guess you are saying that because benign prostate hypertension here, hypertrophy is more common than the prostate cancer. Is that true?
Absolutely. Because
so that's why you want to take up the benign prostate hypertrophy. Benign means which is not cancerous. Prostate is prostate, and hypertrophy means swelling of the gland. Gland swells as you age. Over to you, Dr. Sinha.
Yes. So now we must understand what is BPH. Just brief outline. So BPH, it's, as you can see from the next diagram, that BPH is presentation. Next.
IT, please run his slides.
Yes. Now the BPH, as you can see, that there is a bladder and the prostate is below it, through which the urinary passage goes. Now that is the prostate gland which is present in all males. After a certain age, that is usually 40 to 45, due to hormonal changes in the body, this prostate gland increases in size. And as you can see in the picture, that the urethra is getting compressed. And that is what causes the symptoms due to prostate, due to the enlarged prostate. Next, please. Okay. So the signs and symptoms of prostate. There are two basic groups of signs and symptoms, the irritative symptoms and the obstructive symptoms. The irritative symptoms are the ones which start earlier, like urinary frequency. You have to go quite often. While you are in a meeting, you have to get up and go to, you cannot just hold, that is the urgency. So these are the ones which are irritative symptoms, so it shows that you are developing a prostate problem. Now the prostate problem, we have to understand that the prostate gland is present in everyone, but the symptoms don't happen in everyone. Those who get symptoms are the ones who need some treatment. So the initial symptoms are the frequency, urgency, and you have to get quite a few times at night. So these are the irritative symptoms. And as the disease progresses, the symptoms become obstructive because of the obstruction in the urinary flow. So what obstruction, what are the symptoms that they cause? The poor flow. Usually people think that the flow is, with age, the flow should go down, but it's not so. The poor flow is because of the prostate compressing your urethra. And then when it progresses further, you are not able to pass urine in one go. It stops and starts, stops and starts. So that is the intermittency. And as a result, the voiding time, the time to pass urine is prolonged. And at the end of it, you feel as if all the urine you have not been able to completely evacuate. There is something staying behind. And you have to go again after 15 minutes or 20 minutes to pass urine. So that is the feeling of incomplete evacuation. Next, please. Now, in brief, if we do not take care of the symptoms and try to not listen to what the body is saying, you won't initially know anything, because the symptoms occur so slowly, so gradually, that if you delay, this is what your kidneys are going to end up with. It looks swollen, it looks compressed, and it looks damaged. So there will be urinary retention. Once there is urinary retention, the kidneys won't be able to effectively pass urine into the bladder. As a result, the kidneys will keep swelling and the urea creatinine starts to rise. And as a result, the body swells and the kidneys get destroyed. And it may end up with dialysis. So this is a very dangerous complication. In today's era, thankfully, people are aware and they come much earlier. But still, we get patients who come with bilateral hydroureteronephrosis, as you see in the picture. Next, please. So after we have passed through these basic assumptions, we now go to the myths. Next. Next, please. Next. Okay. Now the first myth that BPH only occurs in older men. Like Dr. Roy said in the introduction, that we think that it occurs between 60 to 65 years. Yes, mostly that. But the development of the prostate, the growth of the prostate, it starts after 40 years or so, because of the change in the hormonal milieu of the body. Just like in females, they have a menopause. Why do they have a menopause? Because there is a hormonal change in their body. As a result, they have a menopause. In our body also, we also develop some kind of hormonal changes. As a result, the prostate starts growing, depending on his genetic predilection. So if you have a history of your father developing a prostate problem, which needed surgery, then high chance that you will need surgery. So be aware of it. So 40 and above is when you should be aware that you might develop symptoms. Okay. So next, the urine flow will obviously decrease with age, which I said before that you do not need.
Go back. IT, go back. Yes.
Yeah. The urine flow will obviously decrease with age. That is another myth. It is not so. If it is decreasing, that means the prostate is causing problem. It is obstructing the flow. So you need to come. And not only that, here you must understand that the prostatic symptoms are the same, whether it is a benign disease or a malignant disease. Understand what I am saying, that the symptoms of a benign prostate as well as a cancerous prostate, the initial symptoms are the same. So it is really dangerous to not pay heed to the symptoms that come on due to urinary symptoms that come. So the urine flow is decreasing. It may not only be just a benign prostate, it can be a prostate cancer. So come early, get yourself tested, and we will all be at peace. Next. BPH is linked to prostate cancer. This is another myth. There is no correlation between the two. Why? Because the origin is different. If you see the picture, there are two zones, as you can see, two egg-like shapes. This is called the transitional zone of the prostate. And the surrounding white area, that is the peripheral zone. Now, transitional zone grows in BPH. That is the zone which you can see the picture. The transitional zone is grown and the whitish zone is getting compressed. That is the peripheral zone. And the peripheral zone belongs to prostate cancer, while the transitional zone belongs to the benign disease. There are some overlap, but broadly, this is the scenario. So if there is a benign prostate happening, that benign BPH has happened, so there will be prostate cancer. No, they are completely two different diseases which have no correlation. We'll come to this later when there are other myths that we will explore. Next, please. Next. Now, BPH should always be treated. Why I'm saying BPH? Because someone has gone and done ultrasound for some abdominal problem, and the report has shown prostatomegaly, that the prostate has increased in size. Now, what do I mean by increase in size? There has to be a mean or median size of the prostate. It is around 18 grams. Now, they have reported a 40 grams prostate, and the patient is very worried. See, I have a prostate problem, what to do? But he has no symptoms. If the patient doesn't have symptoms, whatever be the size of the prostate, we are not bothered. So, not all prostatic enlargement needs to be treated. That is, we have to be very clear in our mind. It should only be treated if the symptoms are bothersome. Now, the other fact is treatment depends on the size of the prostate. Treatment doesn't depend on the size of prostate. As I said, that a large prostate with no bothersome symptoms doesn't need any treatment, be it medical or surgical. While a small prostate, even a 22 grams prostate, is causing such a severe obstruction that the patient's life is affected. In that case, I have to intervene, be it medically or surgically. Initial intervention is always medical. Initial intervention is always medical. And once we see that the medical intervention is not working, then you go to surgical. Now, what do I mean by going not working? If a large prostate, let's say it's a 60 grams prostate, and we have started a medical treatment. The medical therapy, there are two groups of medicines. One is the alpha blockers, which includes tamsulosin, alfuzosin, silodosin. These are the alpha blockers, which causes relaxation of the prostate. It is mainly effective in small prostates. While if it is a large prostate, then we have got another group of drugs, which is called the 5-alpha reductase inhibitors. Now, 5-alpha reductase inhibitors causes a shrinkage of the size of the prostate. So, in prostatics, prostates which are big and which is causing bothersome symptoms, you give a combination of the two, an alpha blocker as well as a 5-alpha reductase inhibitor. So that is how you treat them. The larger prostates usually respond well to medications, while the smaller prostates, they do not respond well to medications, because the smaller prostates are usually more fibrotic. They do not have more gland in it, more fibrous structures in it. So they do not respond well to the medication. So it is mostly, if a small prostate is causing symptoms, they end up more in surgery than a large prostate, which may respond very well to medication. That's something we have to keep in mind. So the treatment depends on the size of the prostate. Is size will only be considered when, suppose I have now decided, as I said, one, for medical management, if it is less than 30 grams, I'll give only 5 alpha blockers. If it is more than 30 grams, I'll give a combination. That is one. Second, if I decide for surgery based on certain parameters, then the size will then dictate what kind of surgery I'll do. Up till 100 grams, a microsurgery, minimally invasive surgery, which includes a laser prostate, which is HOLEP, or it can include the standard microsurgery, which is called the TURP. These are all can be considered. But if it is a larger prostate, then you have got only two options. Laser prostate is still an option, and open prostate, which is the gold standard still, which of course it's now a declining art. Very few new residents would be able to do open prostate, but it is still a very good method. Now, next please. Next. Yes. The side effects from BPH medication are disruptive to your lifestyle. That is a general viewpoint. As a result, people with some symptoms, they do not go to a doctor. Okay, I can live with it, not with the side effects of the medication. The medications really are very good now. When we started our residency period, the medicine that was available as an alpha blocker was, which had a really high side effects. Now, the most important side effect was hypotension. That is the blood pressure drop. 40% of our patients used to drop out of the medications. As a result, we had to go ahead with surgery in most of the cases. But now, with more effective medications, surgery has definitely reduced, but it is still a very, very important modality of treatment. So that is one aspect, that the BPH medications which are presently we use have much less effect on blood pressure. As a result, people do tolerate it for a long time, because these are lifetime medications. Once the prostate medications start, it cannot stop, because the symptoms come back, and they in fact come back with a vengeance. So you cannot stop the medication. It has to go on till life, or till the medications become ineffective. As a result, we go ahead with surgery at that point of time. The second important side effect of the prostate medications are that it causes retrograde ejaculation. That after sex, the semen does not come out. But one thing that we must remember, the semen might not come out, but the orgasm and the sensations remain the same. They are not disturbed in any way. And whether the semen not coming out causes any harm? No, it doesn't, because the semen goes back into the bladder and it comes out with urine. It does not stay back in the body. So the BPH medication, this retrograde ejaculation also is not a problem. What may be problem in some young prostate patients who are active sexually is they can cause a bit of impotence. For that, we use in them alphazocin is very well used. Plus, we can add some stimulants which are now available in lesser doses. So it can be continuously taken and it has a very good effect. So the side effects of BPH medication are very much manageable and there's nothing to be very worried about. We should definitely seek help at the earliest. Too much or too little sex cause BPH. It has got no correlation with that. BPH happens, as I said, because of a hormonal change in the body, which will again be dictated by his genetic predilections. Next, please. Next slide. Okay. Now, surgery for BPH frees you of the risk of prostate. Now, these two myths that are taken together. That number one is surgery for BPH frees you of the risk of prostate cancer, and number two, prostate surgery leads to development of prostate cancer. People come to me with both the situations. Like, স্যার আমার তো প্রস্টেটের অপারেশন হয়ে গেছে, এখন আবার প্রস্টেট ক্যান্সার বলছে, এটা কি করে হলো? তাহলে তার মানে অপারেশন হয়নি? It's not that. The BPH part, as I showed you in that diagram, the BPH part is the transitional zone part. When we operate on the BPH, it will be shown in the next picture that we usually enucleate from inside the transitional zone. Whether we do an open, whether we do a micro, the preliminary theory is the same, that we enucleate the transitional zone, leaving the peripheral zone intact. So the peripheral zone is the zone which is involved in prostate cancer. So that part which usually develops prostate cancer stays behind. And so you might ask, why don't we remove that part as well when we are operating on the prostate? It is because removing the whole of prostate, including the transitional zone and the peripheral zone, is a big procedure. It is only undertaken when we are operating on a prostate cancer patient. And we remove the whole of prostate for localized prostate cancer. Again, for those which have spread out metastatic prostate cancer, it doesn't help. Only in cases of localized prostate cancer, we take out the whole of prostate, and that is best done by robot. And the robotic surgery is available in our hospital, which we do very well, and they have got excellent results. They go home in a day or two, and initially, the commonest complication for those radical prostatectomy used to be incontinence. Very difficult to hold urine, or sometimes they are incontinent for life. Urine keeps dribbling throughout life. Now, with the help of robot, that complication has been greatly minimized. And our patients go home in a day or two, and they are mostly continent. Very rarely do we have incontinence in our patients. So as you understand, that surgery for BPH, which mainly concentrates in the transitional zone, does not reduce the risk of prostate cancer, neither does it lead to the development of prostate cancer, because we are acting only in the transitional zone. A lot of patients come, prostate, like my friend, he went ahead with a prostate surgery and then he developed prostate cancer. It was not he then developed prostate cancer. The prostate cancer developed as it is. It would have developed whether you had undergone prostate surgery or not, because the peripheral zone remains behind. That is the main crux of the whole thing that I'm trying to imply. Next, please. So as I said, in QRP, as you can see, that it is the inside of the transitional zone is the one which expands in the inside. We just take it out as in a coconut. We take out the inside white part and let the outside shell remain. So the peripheral zone remains like a shell after we remove the TRP chips from inside. That is the microsurgery. As you can see, the instrument is going through the penis and we take it out from inside. Next, please. Now, surgery for BPH is mostly unsuccessful. Even if successful, it is short-lived. Surgery for BPH is another myth which we see in we mostly hear in a lot of patients that surgery করিয়েছিল কিন্তু এখন আবার catheter নিয়ে থাকতে হচ্ছে. This is something that we do not hear in today's era. There was a time when we were all learning how to do TURP. That was around 30 years back. But now we are also well trained that we can guarantee almost a certain level of result. One of the most important complications that we used to see with BPH was incontinence, because there is a sphincter at the end of the prostate. The sphincter is a muscle which holds our urine. Now that muscle, if you are, when we are cutting, we are using current, and if the current gets conducted into that muscle, which is a very thin muscle, it gets affected and it is not able to work. So it won't be able to hold the urine and he will become incontinent. We now know what are the landmarks based on which we have to stop at a certain point. We do not go there. As a result, we do not see incontinence in our patients. So BPH surgery is mostly successful in today's era. Decision making, there are other factors which needs to be taken into account, like a patient who has gone into urinary retention may not only be due to prostate, it may be due to a neurological cause. Somebody has had a stroke and he developed urinary retention. Now you cannot reduce his retention or relieve him of his retention by doing a prostate surgery, because the etiology or the cause is neurological. So that won't help. So if you have to, the decision making is important. A patient who is bedridden, who is a long-term diabetes, in these patients, the bladder, the urinary bladder becomes very weak. So it doesn't have the strength to push out the urine. In that case, even if you do a prostate surgery, the urine will stay behind in the bladder because the bladder doesn't have the force to push it out. So these patients, which I mentioned, the conditions, in these patients, we think that there may be hypotonic bladder. The bladder is weak, and we prove it by doing a urodynamic study. Once we know that the bladder is weak, there's no point going ahead with the surgery. In that case, the patient stays on a catheter for life. We can't help it. So these points need to be taken into account while we make a decision, and these points need to be communicated well to the patient as well, so that they understand why it is happening, what is happening, and what needs to be done. As a result, they can expect a outcome which is as per as what the doctor has told them. So we do not see incontinence after surgery. A lot of people feel that the impotence sets in. Impotence does not set in after a prostate surgery, after a benign BPH surgery, that is a TURP or a Holland. The impotence doesn't set in because the nerve for erections are on the outside, not on the inside. So you can no way impact those nerves. So impotence is not a complication of prostate surgery. Next, please. Now, this is Holland. Stay. Yes. So this is HOLEP or the laser. As you can see, the laser fiber which is firing, it's like a orange. The prostate is like an orange, where the peripheral zone is compressed like an orange peel, and the lobes are like the orange inside, and it is peeled out from that. In open prostate also, we peel it out with the help of our finger. In cases of laser, we peel it out with the help of a laser. So the principle remains the same. Either we do open surgery, we do a laser surgery, we do usually thermal energy TURP. The principle remains the same, and we give very good outcome in all prostate surgeries. The patients are very happy with the outcome when we decide to go ahead with the surgery. Next, please. Next. Okay. Now, the most important part. So, is everything inevitable? Nothing can be done to relieve symptoms of BPH? No, there are some lifestyle changes which help. Avoiding drinks with caffeine, because the more you drink, take drinks with caffeine, the urine output, diuresis occurs, urine output increases. So you will have to go more often to the to pass urine. decrease the amount of fluid intake, especially during the night. You cannot completely decrease fluid intake because you need some amount of fluid to excrete the waste matter present, waste products that are produced in the body. That needs to be taken out. So a definite amount of fluid is required. But the more bothersome of the symptom is nocturia, that is getting up quite a few times at night. So as a result, you decrease the fluid intake, especially at night. Here I want to say something as well, that nocturia, getting up at night, might not only be just a prostatic thing, it can also be a age-related thing. What do I mean by that? With age, the blood vessels become more porous, let's say, which we call permeable. So it becomes more porous. As a result, when you are standing or sitting, the whole weight of the blood falls on the foot, and water from the blood, they move out of the using the pores of that blood vessel. And a lot of people say, "Mera pair phul jata hai." So the swelling happens because water from the blood is moving out into the tissues. If water from the blood moves out, then the blood volume goes down. Amount of blood reaching the kidney goes down. So the amount of urine production goes down. As a result, daytime urine output goes down. The reverse happens when he lies down. When he lies down, the leg comes up, the pressure is relieved, and water in the tissues go back into the blood vessels. As a result, the blood volume increases and more blood is presented to the kidney, and there is more urine output. In this case, if there is more urine output, you have to get up and pass urine. There is nothing that can reduce your nocturia. If you are passing copious amounts of urine at night, then your nocturia cannot be reduced. You have to go and pass because your blood vessel, because of age, has become more porous. Nothing can be done about that. Now, avoid decongestant medications. We have seen those nasal decongestants. They have some medications which causes urinary retention. It causes the prostate to become hard or become obstructive. As a result, the patient who are on a borderline flow goes into retention. So those who have prostatic problem, be very careful when you take decongestant medications. You may go into urinary retention. Okay, a diet high in vegetables and low in saturated fat. So what are the low in saturated fat? Nuts. Nuts are very important. They are low in saturated foods. Have a lot of nuts. Have a lot of vegetables. Next, please. Carotenoids. So carotenoids are very important. So take carotenoids, take citrus fruits, oranges, grapefruits, lemons, pulses and legumes, beans, soybeans, lentils, peanuts, groundnuts. All of these are good for prostate. So make these changes. Alcohol intake, reduce alcohol intake. That means no more than 2 drinks a day. That is, you do not need to stop alcohol altogether. You can enjoy your alcohol, and please keep enjoying it in moderation. That is the end result. So next, please. Okay, so thank you.
Thank you, Dr. Sinha. You did a great job.
Thank
You explained very well a lot of myths, and you all will agree that though he got stuck up in theater, but he somehow came running and managed a show very well where he put a lot of myths and facts. He said that it's a very slow growing disease. It does not necessarily belong to the elderly. One can have it after 40. And he also said symptoms to be taken very seriously. See, the best part about this disease is that you become symptomatic. And those symptoms will lead you to a doctor, and doctor will treat you based on symptoms, not on the size of prostate. What he's saying, that size of prostate is of no consequence. If you are symptomatic, I will treat prostate because of symptoms. And he also said, take your symptoms very carefully. And he said that prostate has got 2 areas. One, the center, which is a truly prostate. He showed you orange picture where there's a park of orange. That was the transition zone, which becomes big and small, which is responsible for prostate hypertrophy. And he also said in the same breath that if we operate on prostate for benign hypertrophy, does not mean he will not get cancer. Because cancer happens in a capsule zone, the area around the prostate that become cancerous, and that can happen before or after surgery for benign prostate. So it does not mean that if we have operated on the patient, he will not get prostate cancer. But he says it is easy to deal with it because there are modern treatments available. He said that he has got a robotic robot. He can remove the entire gland and discharge you next day morning. There was a time when the prostate patients had to lie on the bed for 7 days. It's a big bottle. This big bottle used to run in front. This big bottle, almost size of a 5-liter container, and the water used to go inside the urine and then used to flush it. Now, next day, patient get discharged. And also, he said that symptoms decide treatment, not the size or not the radiology finding. The key prostate की size बढ़ के 40 ग्राम हो गई, अब ऑपरेशन करना ही है, करना नहीं करना, जब तक सिम्टम्स ना हो ऑपरेशन नहीं करना है. इन्होंने कहा कि we can treat them with the medicines, and he also said the modern medicines are very safe. There are no side effects. Earlier, 40% of patients used to have a drop in blood pressure, but there's no blood pressure now. In fact, many urologists have gone out of job. Dr. Sujit Sinha will confirm that. क्यों साहब ठीक है ना?
एकदम सही.
पहले प्रोस्टेटिक सर्जन यूरोलॉजिस्ट 10 प्रोस्टेक्टोमी एक दिन में करते थे, अब ये 10 हफ्ते भर में नहीं करते, क्योंकि मेडिसिन हैज बिकम सो गुड एंड यू मस्ट take medicines regularly, and once we start the medicine, you can't stop thing in your lifetime. You have to continue taking medicines. Dr. Sinha, there is a question that other than TURP, what are the intrusive or invasive procedure available for removal of prostate?
Okay, so for removal of prostate, there is called TUIP, transurethral incision of prostate, but the results are inferior to TURP. There is another laser which is called green light laser. Now the green light laser, you put in the laser in between and the laser fires sideways and it keeps eating the prostate gland gradually. But it is such a slow procedure that treating a large prostate with that is a time consuming thing, and the results are not very good. As a result, the green light laser has not been very well accepted by the medical community, except in few centers where they do green light laser. Green light laser has not been very accepted. And another thing, they use a button to enucleate. These are modifications that people use, but really they do not compensate for the TURP or HOLIP. I think these are the two which people should concentrate on.
Thank you. What doctor is saying what about embolization in urolift?
Urolift is a procedure which is done in patients who are very sick, who cannot undergo a big surgery. So in those patients, these urolift surgeries, embolization is done. What do you mean by embolization? Embolization is because the vessels which are supplying the prostate, you are blocking them. So you block them, what happens? The tissue necroses, dies, and necroses and melts away. But embolization and its future, the dying process is very painful for the cells, and you will feel that pain. So it is not a very accurate and not a very worthy procedure. These are all done in patients who are very sick, who cannot undergo a major procedure.
So what Dr. Sinha is saying that still the gold standard is a TURP and HOLIP,
yes,
where you use the laser beams in removing the part of prostate, burning it away basically, and the TURP is standard. And he also said that a small prostate, if it is symptomatic, then it's very naughty because it's a fibrous tissue. It is not a gland inside. The fibers are very difficult to withdraw with the medicines. So probably he will require surgery.
Yes.
So the size doesn't matter. What matters is symptoms. Please remember that. Here, size doesn't matter. I hope my men listeners are very careful listening to it. Prostate surgery is cancer independent. You operate, you can still get a cancer. He says with a lot of confidence, there is no incontinence or no impotence post URP. He also brought out and the fact that there could be reverse ejaculation, retrograde ejaculation, which is harmless. So, but there's no changes in the external behavior or feelings or sensations. It's internal and gets evacuated through urine. So nothing to worry about. And he also said in the conclusion that avoid decongestant. If you are having a prostate problem, decongestant can make your problem a little worse. So please avoid decongestant or talk to your doctor. And said, like everybody else said in all our seminars, that diet, vegetable, and nuts are very important. One more point he pointed out, with that we will conclude today's session. After thanking Dr. Sujit Sinha profusely, he said that nocturia, I want to tell all my people who are listening to me, that nocturia is an urine formed in a bladder in the night. So you have to go to bathroom multiple times. He said there are two origins. If you take too much of water, nocturia is where you have more urine is common. And if by controlling water, you will get rid of it. But he said there's another nocturia or the night urine when the water moves into your tissues. In the night, when you lie down on the flat surface, it comes back to your system. Then you have a copious amount of fluid coming out through urine that cannot be treated by any taking water less. So I think with this, we agree that Dr. Sujit Sinha has done a great job. Thank him. Stay connected. Please remember, these all tips are for you to live healthy. These all tips are here. Medica brings to you every week after week for you to look after yourself in a small manner. Wherever we can help you, we are more than willing to come forward and support you. But we don't want you to fall sick. We want you to stay healthy. With this, we thank Bengal Chamber of Commerce and Industries for supporting us and Rotary Club of Calcutta, Vienna for being our stakeholders in this weekly webinar. Thank you. Have a nice day, nice weekend. Next week, we will again catch up with a very, very relevant topic